Today we will talk about the considerations that you may want to take regarding androgen deprivation therapy if you switch to a hypofractionated radiation therapy regimen for the treatment of prostate cancer. We will review some of the radiation therapy treatment options for prostate cancer. We'll look at the efficacy and the cost, and we will do the same thing for androgen deprivation therapy. For reference, these are the current NCCN guideline recommendations, the definitions of the risk groups, which we will discuss in the subsequent slides, and we'll talk in detail about the recommendations for radiation and hormones. And as a summary slide of what you will see, we'll talk about the use of observation versus radiation therapy, short course hormone therapy or androgen deprivation therapy, which is typically defined as use for about 3 to 6 months, long course hormone therapy, which is 18 to 36 months usually, and all of the different considerations surrounding these. So to start, let's talk about low to favorable intermediate risk disease. The PROTECT trial established the efficacy and toxicity of radiotherapy, surgery, and surveillance for many of these patients. This trial included 1,600 patients. The majority of them had screen-detected prostate cancer, that is T1C disease, which could not be palpated. The majority also had Gleason 6 prostate cancer. The median PSA was only 4.6. And so most fell into the low or the favorable intermediate risk subgroup. The results of this study have been published back in 2016 and most recently in this year in the New England Journal. This trial showed that for the patients who were enrolled in the active surveillance arm, about 50% were treated at about 10 years. There was slightly more disease progression and metastasis progression with the active surveillance regimen. However, the rate of prostate cancer specific mortality at 10 years was less than 1% for all of the patients in the trial. For reference, the use of moderate hypofractionation versus conventional fractionation has now taken over. And so the majority of patients who are treated now receive at least moderate hypofractionation, if not extreme hypofractionation, which I'll show you in a minute. These are the most recent trials and the largest trials that have been run around the world for the use of moderate hypofractionation. And what you can see is a very similar theme, similar outcomes in terms of biochemical failure and survival, and also similar rates and very low rates of GU and GI toxicity. What about the use of stereotactic body radiation therapy, also called ultra-hypofractionation or stereotactic ablative radiation therapy, or SABR? So here is a meta-analysis from Dr. Spratt's group that was published in 2019, looking at biochemical failure-free survival. You can see that the majority of patients have excellent biochemical control at 10 years after treatment. And in general, the urinary and the bowel toxicity is limited, and it returns to baseline after about 2 years for most patients. Similarly, our group did a meta-analysis comparing ultra-hypofractionation with moderate and conventional fractionation, and we similarly noted that the biochemical disease-free survival, GI toxicity, and GU toxicity was similar. So what are some of the logistics of stereotactic body radiation therapy if you choose to treat one of your patients? In the era of COVID, one of the considerations was to possibly delay the start of radiation therapy with androgen deprivation therapy if needed, and then proceed to CT simulation and consider possibly getting an MRI and placement of fiducials or a spacer. Now, I'll talk about some of the cost implications of all of these soon. Our group put out this review of how to proceed with stereotactic radiation therapy during the era of COVID. And we have some of the fractionation regimens and also some of the scheduling logistics displayed here. So in general, the treatment will be delivered every other day, or maybe twice per week, or once per week, but not every single day. What about the cost of radiation therapy? So the cost typically varies by country. in the US, SBRT costs about $10,000. However, in Canada, the cost is only $1,000. However, globally, in general, the cost is fixed for the initial patient consultation, for the treatment planning, and it increases with the increasing number of fractions that are used because of the increase in personnel and time. The majority of the cost difference amongst the fractionation schemes comes from the treatment delivery. So here is an analysis from Dr. Kishan's group. Dr. Kishan, if you all didn't know, is one of the collaborator with Dr. Spratt to create the MARCAP consortium. And so some of that data we've looked at already, and I'll show you some more of their data in the coming slides. So here you can see that the cost of planning and physics, the treatment devices, physician management is relatively low and similar among conventionally fractionated, hypofractionated, and ultra hypofractionated. However, the treatment starts to increase for the treatment delivery, mostly for conventionally fractionated radiation therapy. And this is, again, because of the increase in personnel time. What about the cost of image guidance for radiotherapy? So there are limited trials that compare various forms of image guidance. These things include something like a daily cone beam alone, plus or minus fiducials, or daily KV orthogonal imaging. Right now, daily cone beam CT without fiducials is probably the most economical way, and it may be recommended for all hypofractionated radiation therapy patients and also select cases of SBRT. Daily KV imaging is an option. However, it has several limitations. Number one, physicians cannot evaluate bladder and bowel filling, and it typically also requires fiducial placement at an added cost. The use of a rectal spacer for prostate cancer is somewhat controversial. Most recently, there has been a study published in JAMA Oncology. This is a non-inferiority study of acute toxicity that included mostly patients with T1 to 2 disease, mostly low and intermediate risk disease. It had 200 patients, and the men were randomized to either receive a spacer or not. Their primary endpoint was a reduction in the rectal dose, and they did meet this endpoint. However, there was no change in patient-reported quality of life. So here on the right side, I'm showing you the figure of patient-reported quality of life at 3 and 6 months after the procedure, and you can see all of the p-values are non-significant. The group also evaluated the physician-reported toxicity with the RTOG scale, and you can see that there were slightly more patients in the non-spacer group who had a higher rate of physician-graded toxicity, but some physicians may say, well, if you look at the quality of life metrics, they're very similar. So is the spacer really worth it? The cost of a spacer varies. The most recent cost analysis from Canada showed that it cost around $3,500. And the group also calculated something called the incremental cost effectiveness ratio, and they looked at the cost per quality of life adjusted year. So this metric varies really depending on what you put into the model and what the cost of spacer would be in your group and in your country to put a spacer into every patient. There are different and subjective cutoffs for what physicians would say is a good value per quality. And usually this value is somewhere around $100,000, where we would say that it is no longer cost effective. So the lower the value, the better it is. And you can see that in many cases, these values were, $39,000, $96,000. And so the authors of this article said that the cost of effectiveness contains substantial uncertainty because it really varies, and that they recommend more studies to look at the cost effectiveness of a spacer. Okay, let's next talk about hormone therapy for prostate cancer. So in general, orchiectomy would be the cheapest and the most effective method for decreasing androgens. However, it is rarely performed, and it is sometimes considered for non-compliant patients. Almost all of the trials of medical androgen deprivation therapy have been from the conventionally fractionated era, and we have extrapolated their use to the hypofractionated era. We assume that the efficacy for most drugs is similar in the de novo setting, and there's currently limited prospective evidence of SBRT for high-risk patients receiving hormones, but it seems to be reasonable and it seems to be very similar. If you look at the NCCN guidelines, the NCCN will tell you that for unfavorable intermediate risk disease, the recommendation is about 4 to 6 months. And for high risk disease, it's 18 to 36 months. Now, I'm going to show you in the next few slides why I don't think going past 18 months is a good idea. There are different types of hormone therapy. So first, we'll talk about androgen deprivation therapy, or ADT. This temporarily increases androgens, but then decreases androgens, thus lowering testosterone. The drugs that are in this group are the GnRH agonists and antagonists, and so I'm listing some of them here. Leuprolide and leuprorelin, or Lupron and Eligard, are probably some of the most common. Degarelix, relugolix is one of the newest agents that's available, are also options. The study that has evaluated relugolix suggests that cardiac events may be lower with this drug versus other medications. And one of the considerations where you may want to use relugolix is if you need fast testosterone recovery and the patient desires an oral medication. But I'll show you some of the cost considerations of a drug like relugolix versus the old school drugs like Lupron and Eligard, which are probably more cost effective. The next set of agents that we think of are anti-androgens, or androgen receptor antagonists. These are not ADT, and they are not a substitute for ADT. They actually increase circulating androgens. They may be started prior to ADT if there is a concern about a testosterone flare from agonist medications in high burden metastatic patients. And so if you want to avoid a painful flare among patients with widespread metastatic disease, you may want to start this anti-androgen before you give a drug like Lupron. So patients are usually on a medication like this for a month or so, and then they are transitioned off of the drug. The first generation drugs include bicalutamide, or Casodex. This is one of the oldest drugs, and it's been used in many clinical trials. If it's given with Lupron, the dose is 50 milligrams per day. It has also been used as a monotherapy at 150 milligrams per day, and it has been shown to have similar outcomes to castration. However, in general, Casodex or bicalutamide is not used at a dose this high because the toxicity rates are relatively high and patient compliance and tolerance of the medication is low. We also have second generation anti-androgens, or androgen receptor signaling inhibitors, ARSI, or novel hormone agents, NHA. These are all abbreviations that are often used by medical oncologists who prescribe these. So some of these drugs include abiraterone, which is given with prednisone, enzalutamide, darolutamide, and apalutamide. And many of these drugs you will recognize from currently ongoing clinical trials. These drugs are always given with ADT. However, not all of these agents have the same effect on testosterone and their ability to drop testosterone levels. Androgen deprivation therapy is combined with an anti-androgen that is something called complete androgen blockade, or CAB, as you may see in the literature. This is typically used for patients with metastases, and its use has decreased now because ADT is being used with ARSIs, which work better than bicalutamide. So why don't we use a drug like bicalutamide in place of ADT? This is a trial run from Princess Margaret in the 90s and 2000s that included mostly men with intermediate risk prostate cancer who received dose-escalated external beam radiation therapy. They were randomized to 5 months of neoadjuvant and concurrent bicalutamide. This is at 150 milligrams once daily versus not. So again, 150 milligrams is the monotherapy dose. And you can see all the characteristics of the trial, but the important take home is that the biochemical failure rates, overall survival rates, and the local control rates were all similar. but we know that with ADT, the outcomes should have been improved. So if one were using a drug like Lupron. What about the pricing of ADT? So the price is determined on something called the wholesale acquisition cost. And this is an estimate of the manufacturer's list price for a drug to wholesalers or to direct purchasers. It does not include discounts or rebates. The pricing of hormone therapy is dissimilar from radiotherapy because it mostly depends on the agent that is used. There is some dependence on the duration of therapy, but there's no dependence on the staff, and the price can also be variable through the practice and the negotiated contracts that large payers have, and there may be discounts for certain medications, or there may be a service fee. It's also sometimes cheaper to give these medications at home with a home nurse or a home aide rather than having the patient come to the hospital. Here I'm showing you some of the wholesale acquisition costs for the common ADT drugs. So Leuprolide and Leuprorelin, these are very similar drugs. One is intramuscular, one is subcutaneous. And here I'm showing you the cost for a 3-month injection or a 6-month injection. You can see it's about $6,000 versus $12,000 in the US. Eligard is around $1,000 or $3,000, depending on the dose. And for bicalutamide, this is, again, the anti-androgen, the oral medication. So the cost is something like $500 per month. Relugolix is the most recent agent that we've seen used, and its cost overshadows the cost of drugs like Lupron and Leuprorelin. And so there are questions, is this really cost effective versus a drug like Lupron? What if we compare the wholesale acquisition costs in Colombia versus the US? So here I'm just showing you the differences between the two countries. The US is different from Colombia in that the US has insurance plans versus in Colombia, there's universal health coverage. And in Colombia, only Leuprorelin is not included in the plan. In the US, it really depends on what plan the patients are on and what drugs may be covered. So the pricing may also be different on the brand and the generic availability in different countries. But in general, I would say that Leuprolide or Leuprorelin is probably the most cost efficient at about $500 per month. But this cost also does not consider drug-specific toxicities. What are some of the toxicities that you may consider? So in general, with all of the hormone therapy agents on the left side, you would worry about things like weight gain, lipidemia, insulin resistance, cardiovascular events, muscle loss, etc. There are also drug-specific toxicities. So with bicalutamide, the chief concerns are hepatotoxicity, diarrhea, and gynecomastia. And one of the benefits is that this drug can be discontinued quickly if physicians note these toxicities. With Leuprolide and Leuprorelin, there is a greater concern for hot flashes, bone loss, and fractures versus a drug like bicalutamide. There also can be an increased risk of diabetes and heart disease, but not necessarily an increase in cardiac deaths. And so many physicians, when starting these medications, will also get a baseline bone scan. They will supplement calcium and vitamin D. And these medications come as a depot injection, so they will stay in the system for 1 to 6 months. So they can't just be quickly discontinued like bicalutamide. What are some of the ancillary medication costs? So if a patient is at high risk of osteoporosis or fracture, we may consider the use of denosumab, and the cost you can see here varies from about $1,600 to more than $3,000 per year. Oral bisphosphonates are cheaper, but they have less supportive data. And there's also a drug called alendronate, which is about $10 per month. Additionally, hot flashes may be a significant concern for these patients, and these medications can range in cost from about $10 to $400 per month. And the medications include things like oxybutynin, gabapentin, and venlafaxine. Now, interestingly, radiation oncologists will also use oxybutynin for patients who have bladder spasms or maybe have difficulty maintaining a full bladder. So when oxybutynin is prescribed, it may actually help with two goals in the treatment process. Treatment intensification with systemic therapy for localized disease is a little bit limited. So the data are premature right now to suggest anything but abiraterone. And abiraterone seems to have benefit mostly in either very high-risk disease or node-positive disease. There have been trials that have tried to escalate systemic therapy by using docetaxel, but they have all been negative so far. As part of the MARCAP consortium, this was just presented at ASTRO last year, Dr. Kishon, Dr. Spratt, and I, and many of the PIs and the leaders around the world of radiation therapy plus hormone therapy in many of the clinical trials that have been used, we did a patient-level data meta-analysis to determine the ideal duration of hormone therapy for men with intermediate and high-risk disease. In this figure, what I'm showing you is the change in ADT duration going from 0 to 6 months, 6 to 12 months, and so on. This is plotted on the x-axis. The benefit in overall survival on the y-axis, and we're also co-plotting the number of patients that need to be treated with hormone therapy to achieve a particular benefit. And we have 4 plots here. If you have 1 intermediate risk factor, 2 or more intermediate risk factors, patients with high-risk disease, and those who fit the STAMPEDE high-risk cohort. So what you'll notice is that if you just have 1 intermediate risk factor, there's really no good data for extending the duration of hormone therapy past about 6 months. And you can see that the number needed to treat, or the NNT, is 94 plus patients. Most physicians would say that a good number needed to treat is about 20 or less. So most physicians will recommend a treatment if it's 20 or less. And even that has a gray area. But if it's something like 100 or more, it's probably not worth it. For men with 2 or more intermediate risk factors, you can see that the slope of the red line is lower, and now the number needed to treat has decreased. And so the interesting thing about these patients, and this is often for unfavorable intermediate risk disease, we now have trials such as NRG GU010 that is evaluating the use of a genomic classifier to either escalate or de-escalate the use of hormone therapy. For high-risk patients, this is on the bottom left panel, there is usually limited benefit of extending hormone therapy past about 18 months. And I'll show you on the next slide more of this data in detail. And finally, for STAMPEDE high-risk patients, you can see that there is a benefit to many of the patients, going past 18 months, and the number needed to treat may still be low, but we know that these patients actually need treatment intensification. And so that's why many of these patients are also treated with abiraterone. If we plot all of the trials that were included in the previous plot, and what if we look at the other cause mortality, so death from things like heart disease, stroke, etc., and prostate cancer specific mortality. What we want to try to do is we want to try to improve prostate cancer specific mortality as much as possible while minimizing other cause mortality, because we know that hormone therapy will increase the risk of other cause mortality with treatment prolongation. That's exactly what we find in our study. If we go past something like 18 months, the other cause mortality continues to increase, but there is a plateau in the prostate cancer specific mortality. The next group are patients with regional disease or clinically node positive disease. This is an overall understudied population with limited trials. And historically, we know from the Messing study that for patients with pathologically involved lymph nodes, the only option was lifelong hormone therapy. And this has generally been discontinued throughout most practices because lifelong hormone therapy has such a negative or detrimental impact on patient quality of life. The current guidelines for clinically node-positive disease are to treat patients with definitive radiotherapy and androgen deprivation therapy, plus abiraterone, plus prednisone. And so the recommendations are very similar to high-risk disease for the duration. It's about 18 months of hormone therapy. And if you're using radiation therapy, you should probably treat the pelvic lymph nodes. Well, you should treat the pelvic lymph nodes because the pelvic lymph nodes are involved. Now, how can you treat the pelvic lymph nodes? What's the most cost-effective way? There's two possible methods. Number one is to use a hypofractionated regimen. So that is 20 to 25 fractions. And this is something like the CHIP regimen. So you would treat the pelvic lymph nodes to 44 gray in 20 fractions. You can boost involved pelvic lymph nodes up to about 55 gray in 20 fractions. And then you still treat the prostate to 60 gray in 20 fractions, which was the CHIP regimen. The other consideration is that if you start these patients on hormone therapy, after about 2 months, the involved lymph nodes may greatly decrease in size, and they would be easier to treat, and so you may not need to boost them. Another option, this is being explored in Canada, is just a 5-fraction approach. So this is Dr. Loblaw's group and the Saturn trial, and their group is treating the pelvic lymph nodes electively to 25 gray in 5 fractions. They are boosting the involved nodes up to about 30 to 40 gray, as long as they mind the nearby organs at risk, like the plexus, the bowel, and the bladder, and they're SBRTing the prostate to about 35 to 40 gray in 5 fractions. This is also a great treatment approach, and we've actually been using this approach in other cancers. So if you think of rectal cancer, which many physicians will use the short course radiation therapy or 5x5 pre-op approach, it seems to be very safe, and so why would it not work also for prostate cancer? Next, let's move on to oligometastatic disease. With oligometastases, we know that stereotactic body radiation therapy to the metastases seems to be a great treatment option, and it's possible to also hold the androgen deprivation therapy. So here I'm showing you a meta-analysis of the local control of stereotactic body radiation therapy, and you can see it's in general something like 95%. And that makes us think, well, why would we continue ADT if the SBRT is eradicating all of the disease? There are also several trials now that have evaluated radiotherapy to metastases, specifically for prostate cancer, and they have looked at improving ADT-free and progression-free survival for oligometastatic prostate patients. So these trials include the STOMP, ORIOLE, and the EXTEND trials, and you can see that all of them have met their goal. And so these patients can be spared the lifelong toxicities of hormone therapy. For metastatic disease, orchiectomy would technically be cheaper than almost all other forms of systemic therapy, but it's rarely done. And right now, for metastatic disease, the treatment intensification, I should say this is more for widespread metastatic disease, or it also applies to widespread metastatic disease. One can consider docetaxel, which is more cost-effective than abiraterone, enzalutamide, and apalutamide. However, triplet therapy, that is with docetaxel and darolutamide, or ADT and docetaxel and abiraterone, has been shown to be superior to docetaxel. So this is kind of a new space now, and there are different considerations for these patients. Let's next talk about post-prostatectomy radiation and androgen deprivation therapy. If you read the NCCN guidelines, the guidelines have been unchanged for the past 10 or 15 years. They've generally just recommended observation versus radiation plus or minus hormones, and there has been limited recommendation or a solid recommendation for any approach. Our group recently put out this review article. We go into detail about in whom you should consider radiation therapy and in whom you should consider adding hormone therapy. And in short, what our review focuses on is when to add hormone therapy. And the cutoff for many clinics is around a PSA of 0.6 or 0.7, and that was based on a secondary analysis of RTOG 9601. Now, there's new data that's coming out from the Radicals HD trial, and I think in the subsequent years we'll have a even more thorough discussion of the timing and the duration of hormones. So in the post-prostatectomy setting, I would say that for cost, right now, radiation therapy is delivered in conventional fractionation, so it's 2 Gray fractions for most patients. However, hypofractionation is being explored, and this was recently presented at NRG GU 003. This was presented at Astro just 2 years ago. The quality of life seems to be exactly the same, but maybe until the publication is out, most physicians may feel comfortable to use conventional fractionation. For ADT, I would consider just Lupron. And so I would add this to high-risk patients. If you want just one number, you can say, well, a PSA of greater than 0.5 and consider hormones for a short duration. But there are other features and other characteristics of the patient that you may want to consider to start hormones or to potentially consider a longer duration. So in conclusion, we would not recommend the use of radiation therapy or hormone therapy for low-risk patients. Once patients have favorable intermediate risk disease or above, you could consider the use of hypofractionated radiation or stereotactic body radiation therapy, which is probably the cheapest form of radiation to use. A rectal spacer right now has been shown to have no changes in quality of life, and there are value studies that are being performed. But I would say that the rectal spacer is not mandatory, and especially if cost is a consideration, you don't need to proceed with it. If adding Lupron, and that's probably your hormone therapy agent of choice, the cost will be about $500 per month. For unfavorable intermediate risk disease, it's about 4 to 6 months total. For high-risk disease, I would probably not go above 18 months. And so I would avoid overuse of hormone therapy because it'll increase the risk of other cause mortality while having a minimal benefit to prostate cancer specific mortality. For regional risk disease or clinically node positive disease, we would just treat the pelvic lymph nodes in addition to the prostate. And here the hormones are similar, they're 18 months, but we also add abiraterone and prednisone. For patients with oligometastatic disease, stereotactic body radiation therapy to the primary metastases is the current treatment approach that's being explored in many randomized trials. And you can consider long-term hormones, but also you can consider stopping it and monitoring the PSA for progression. And finally, post-radical prostatectomy patients, there's radiation therapy for select patients, usually in the salvage setting. And we consider adding ADT for select high-risk patients. So usually a PSA of 0.6 or above if you're just looking for one value. But there are many other variables like the Gleason score, the doubling time that may impact your treatment decision. And again, we want to avoid lifelong ADT or ADT alone in lieu of radiation therapy for these patients because it is non-curative and has such a detrimental impact to quality of life. And here's the summary again in just a table format and some of the references that you've seen throughout the presentation. And with that, I want to thank you all for having me today, to Alejandro and the Rios team.
Wow, Nicolas, thank you. That was an amazing lecture and also a great summary. Tenemos algunas preguntas y vamos a empezar con ellas. Tenemos un participante, se llama Diego Juárez. Le voy a dar en este momento para que pueda activar su audio y te haga una pregunta en vivo. Adelante, Diego, te estamos escuchando.
Hola, buenos días. Gracias, thank you, and congratulations. In patients with prostate cancer and positive pelvic nodes, I have 2 questions. What is the maximum dose given to the lymph node, and how long do you recommend getting androgen deprivation therapy?
So this is patients with clinically involved lymph nodes, you said?
Yes.
So if you're using a hypofractionated regimen, so something like in 20 fractions, I think it's safe to treat the lymph nodes up to 55 Gray about. But one consideration is to start the hormone therapy for about 2 months. So you will have cytoreduction and the volume of disease will be smaller and it will be easier to meet the dose constraints.
Ok, porque, bueno, lo voy a comentar en español, porque se me dificulta un poco.
Adelante, Diego, no hay ningún problema. Tenemos también traductor en vivo para él en inglés. Puedes
Sí,
hablar en español. Adelante, sin problema.
lo que pasa es que, por ejemplo, le comento este caso muy puntual. Hombre, 75 años, antígeno prostático de 272, Gleason 8, pero tenía un PET donde captaba, se lo leo textual, vesícula seminal izquierda con PET con PSMA, claro. Vesícula seminal izquierda con foco hipermetabólico de 5.7 SV. Yo decidí dar un tratamiento con fraccionamiento convencional en lugar de dar un hipofraccionamiento porque me daba cierta incertidumbre utilizar un esquema hipofraccionado debido a que el volumen iba a ser más grande debido a las adenopatías pélvicas. Pero alcancé a darle con medio de Halcyon hasta 80 Grays a las adenopatías. El paciente sigue en vigilancia, apenas va a cumplir el año de terminar la radioterapia y eventualmente le voy a pedir un estudio de imagen de control para ver cómo ha respondido al tratamiento.
That sounds like a reasonable approach. I think there are many approaches for these patients. And, I think you're thinking of all of the right things, getting the PSMA PET and tailoring your dose based on the PET and the organs at risk.
También los ganglios pélvicos. Adelante, Nicolás.
Sure. So that's a great question. And, I think the question centers around patients with a persistently elevated PSA after surgery. And so there are, I'm going to share my screen in a second.
Yeah, of course.
There's a couple other slides I want to show you all because we have different considerations. Hold on for just 1 second. So if you read the guidelines, there's no consensus on what to do for many patients in the post-operative setting. And the question is, should we as physicians observe these patients? Should we give radiation therapy to the prostate plus or minus the pelvic lymph nodes? And when should we add hormone therapy? And the guidelines have been unchanged for 15 years without clear delineation. So our group, I polled something like 40 different physicians, radiation oncologists, medical oncologists, surgeons, on what their considerations would be and what information and data they take into consideration. So let me share my screen. This is available online. Hold on, can you see the screen?
Sí la podemos ver.
Okay. So hold on 1 second. Let me just share. Okay. So I think that we can break these patients down into multiple categories. And these are the considerations and the scans and all of the variables I would consider, from age to performance status, comorbidities, the risk groups, the post-op PSA, the PSA when you see the patient in your clinic, the interval to biochemical failure, and the PSA doubling time. For patients who have a persistently elevated PSA after surgery, to me, that usually implies that there is undissected disease somewhere in the body. It could be in the pelvis, or it may be somewhere else in the body. And usually, for me, these patients fit into one of these groups in the red columns. So the PSA, if the PSA is something like, 0.5 or 0.2, if it's relatively low, then I think getting a PSMA PET, and if the PSMA PET does not show anything and you still want to treat the patient with definitive intent, I would treat exactly like you said, the prostate bed plus or minus the pelvic lymph nodes. And I think there's controversy, and you could suggest either schema. If the post-operative PSA is something like 2 or 3 and it's rapidly rising, let's say that you check it, 3 months later and the PSA is now 10, it's very likely that the prostate cancer is no longer just in the pelvis. It's probably somewhere else in the body, and maybe the PSMA PET is not detecting the disease, or There's something else going on. And so, in that setting, maybe you want to hold off on pursuing radiation therapy to the pelvis because the disease will be outside of your volume, where you anticipate that the disease will be outside of your volume. So I think there's discrepancy, and there's currently no one set standard. And I think we have to look at the PSA, the postoperative PSA, in conjunction with many of these other variables to select an ideal treatment plan. This will be available online. I'm gonna stop sharing this screen. I'm gonna share something else in a second. So there are also patients, hold on one second. Okay. There are patients in the post-prostatectomy setting in whom we have a very high risk and a suspicion for occult metastatic disease. To me, these patients and the factors that are most worrisome for occult metastases are exactly like you said, a persistently elevated PSA. And the higher it is, the more I am suspicious. A short doubling time of less than 3 to 6 months. If the patients have a very high pelvic lymph node and pathological lymph node burden. So for example, more than just 2 to 3 lymph nodes that were removed have disease. And if they have a high absolute post-op PSA, so when you're seeing them in clinic after surgery and suddenly their PSA is like more than 5 to 10, I'm thinking they must have metastatic disease. There are other potentially worrisome features, such as a short interval to biochemical failure, T3B or T4 disease, grade group 4 or 5 disease, negative margins as opposed to positive margins. So usually negative margins means that there's no more disease, where the prostate was. So if you're considering salvage radiation therapy to the prostate bed, maybe you're going to be missing the where the cancer is because the margins are negative, and a high genomic classifier score. I think that there are 4 main options that physicians have for these patients. Number 1 is to proceed with salvage radiation therapy to the prostate bed, plus or minus the pelvic lymph nodes at the earliest time possible, and to also consider hormones at the earliest time possible. And I think that this is the most common strategy that physicians around the world, I think, are using right now. And the thought is that if the disease is limited to the prostate bed or pelvis, the treatment may be curative. It's early radiation therapy, and so that's associated with improved metastasis-free survival, although we don't have a prospective randomized trial that's suggesting this right now. And we also know that the treatment of the primary will improve overall survival in patients with high-risk localized disease. And this is in part based on some of the data from Stampede. So if there's limited disease, even with metastases, if you radiate all known disease, there should be improved survival. I think some of the disadvantages of this strategy are that the majority of these patients will still progress distantly, and we just don't know who. And we may not expect radiation therapy to be curative or to improve survival. We also know that salvage radiation therapy will have its own toxicity, and it can lock in incontinence. So if the patients are not fully stabilized after their surgery in terms of their GU symptoms, the radiation therapy may actually be harmful. Additionally, the use of hormone therapy will make your PSA unintelligible, right? You won't know if your treatment succeeded or failed, or at least your radiation therapy, because your PSA will go back to undetectable levels. And so your imaging will also have limited accuracy because all of our imaging is PSA dependent. Even PSMA PET scans, we would generally not recommend below a value of like 0.2 or 0.3, and your PSA will be less than 0.1 once you start hormones. A second option is to start hormone therapy now and do salvage radiation therapy later. So the thought behind this is that your hormones will provide a bridge until incontinence improves, and then you can start salvage radiation. The benefits and the risks are similar to the above, but now the patient will have time to regain their continence. Option 3 is to start radiation therapy now, but to hold off on hormones. And I think the benefit here is that if the recurrence is in the prostate bed or the pelvis alone, this treatment may be curative, and you can avoid the toxicity of the hormones, and you will also have an intelligible PSA. You can monitor the PSA after the treatment. And if the PSA does not decrease, then you can make a decision. Do you want to start hormones? Do you want to recheck a PSMA PET scan? Whatever it might be. The downside is that based on many works, we know that for these patients, the majority of failures will be distant and not local. So radiation is probably not going to be curative, and it will only add toxicity. And again, these are different, scenarios and different options for different patients. And I would say that no one treatment strategy would benefit all patients. The fourth option is to monitor their PSA rise and recheck a PSMA PET. Now, I think this is controversial, and many facilities will not have the luxury of just rechecking a PSMA PET scan. And in the US, insurance companies will not pay for repeat PSMA PET scans. But once your PSMA PET becomes positive for something and you see the disease, you can initiate hormones and/or salvage radiation and/or metastasis-directed therapy depending on where it's positive. And so here, the benefit is that the location and the burden of disease will be better characterized, and you can really tailor the patient's treatment strategy, and you can spare patients the toxicity of salvage radiation and hormone therapy. And so right now, this strategy, there are no guidelines to suggest that this is a strategy. There's no guidelines about when to recheck PSAs and PETs. And we also know that PSMA PET scans cannot detect lesions less than 1 or 2 millimeters in size, and this can still be millions of cells. And we also know that per the Osprey trial, the sensitivity is about 40% for lymph nodes less than 5 millimeters. And so even a PSMA PET scan is not an ideal test to monitor these patients. Finally, we know that late salvage radiation therapy has a lower success rate or is associated with worse outcomes than early salvage radiation therapy, and presumably because this is the development of metastatic disease. So I think your question is excellent, and it's the tip of the iceberg. There are so many different considerations and so many different treatment strategies, and we just don't know which strategy is best for all patients.
Nicolás, muchas gracias por toda esa información y compartir